Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have Dr. Adriana Rossi, who's assistant professor and who is the co-director of the CAR-T program at the Myeloma Center of Excellence at Mount Sinai Hospital in New York. And today we're going to be talking about measurable residual disease. Welcome, Adriana.
Thank you so much. It's my pleasure to be here.
Thank you for joining us today. And I think today we're going to just talk about first response assessment in myeloma. A lot of patients want to know how their disease is doing, and then we'll hone into the role of measurable residual disease in response assessment. So how do you assess response? What's stable disease? What's minimal response, partial response, very good partial response, and complete response in myeloma?
Yes, so I think we're lucky that at least 80% of our patients will have an M spike that we can measure, and that gives us a nice number to follow. And we're fairly simple. We like to watch that number decrease, and we've just drawn the line in the sand across the way. So a 10% decrease is the minimal response. Stable disease is less than that. If we manage to get down to 50% reduction, then we like to call that a partial response. A complete response, of course, is the 100% of the way there. And we couldn't resist the very good partial response, which is 90% reduction. And even though it is a mouthful, I think we've learned along the way that getting 90% of the way down really is better than not being able to cross that threshold of 90. So it is an important category for us.
So I'm told now that even complete response is not really meaning eradication of disease, and we have better ways to, diagnose disease that is left even after a complete response. So that's a little confusing. One hand, you say you're in complete response, and then you say you have more disease left. How those two things reconcile?
Yeah, I think this is one of the really good problems that we have in myeloma, is that we're making such fast progress. Maybe our language isn't quite keeping up. And the concept is the same. A complete response is when we can no longer find myeloma. But with time, our tools to find that myeloma are getting better and better. So I do really like the slide with the picture of the iceberg, because again, as hematologists, we started with blood tests, and that M spike we were talking about is the blood test, the blood marker to show us myeloma. And that's really the visible part of the iceberg. But we know that the tumor itself is in the bone marrow. And so what's happening below the scenes, unfortunately, at this time, we're still really depending on bone marrow biopsies to see that depth of response. But even that term minimal residual disease, I think we keep redefining. We started off looking at 1,000 cells. We then started looking deeper and deeper and deeper. And I love this ambitious plan of going down to 10 to the minus, fill in the blank. It's really impressive progress.
Yeah, I guess when a pathologist looks under the microscope and he says there are no myeloma cells, I guess he's just talking about 100 cells or so.
Exactly. So we have the original pathology, which for us, actually, we're very lucky to have great partners and can get that answer in maybe 3 to 4 days. Someone will look at the biopsy and say, we can't find myeloma, or there's a few cells left. But the 2-week turnaround is for us to get that deeper information. And so in addition to looking at the pictures and the slides under the microscope, we routinely do flow cytometry, which is now not so new technology, but our ability to use it and the depth of information we're able to get does continue to improve. And that's a machine that pretty much looks at the outside of the cell and counts how many cells go through that have a specific marker. So it helps us identify, for example, plasma cells that are normal from those that are myeloma, from those that are not plasma cells, and gives us a landscape of how many normal, healthy members of the immune system